Rotator cuff tear scenario can come with a large tear. Large tear will have reduced range of motion. Small tears would be complaining of pain. Rotator cuff tear incidence increases with the passage of age, with increase of age, 20% in age 60 and 50% in age 80. There are cases of asymptomatic tear. Regarding classification, the classification is longitudinal, U-type, crescent type, and L-shaped. The causes can be extrinsic or intrinsic. The extrinsic is because of impingement or osteophytes. Intrinsic is age, hypovascularity, or diabetes mellitus. Ultrasound is in a mean line to direct the intraarticular pathology. It has best guidelines have shown ultrasound as equivalent to MRI in detecting full thickness tear. Regarding the size of the tear, ultrasound is not reliable, and also in partial thickness tear or bursal side tears, the measurement is not accurate with ultrasound. MRI is better than ultrasound in patient with osteoarthritis or frozen shoulder, as they cannot move. Ultrasound needs the shoulder to be abducted and external rotated points. A medial bicep tendon subluxation indicates subscapular tear. Regarding classification, Gothaler classification is important. 0 is normal muscle, 1 is some fatty streak, number 2 is less than 50% fat muscle atrophy, 3 is 50% muscle atrophy, 4 is greater than 50% muscle atrophy. Regarding treatment, depends on the symptomatology. Number 1 is pain relief, number 2 is rotator cuff and deltoid strengthening as scapular stabilization exercises. Surgery indication: number 1, symptomatic tear failing to respond, conservative management. Number 2, reduce activities of daily living and pain. Number 3, partial tear in young patient who needs, and debridement in old patient. Treatment can be mini or arthroscopic. RCTs have shown that there is no difference between postoperative outcome and incidence of re-ruptures. Decrease postoperative pain and short-term arthroscopic repair. The technique is side-to-side repair with marginal convergence or end-to-bone repair. Prepare a shallow footprint at the level of the tendon insertion lateral to the articular surface and allow tendon to cancellous bone healing. Can do single row or double row repairs with bone tunnels. Double suture technique, mattress suture in the medial row and the simple sutures on the lateral row. UK cuff trial 2017. UK cuff trial, open versus arthroscopic in older than 50 years of age. No difference in clinical outcomes in 2 years. Management of recurrent or massive tears. Pectoralis major transfer for subscapularis. Latissimus dorsi transfer for supraspinatus and infraspinatus tear. Need intact subscapularis to counter pull. Critical dead man angle is ideally should be 45 degree. Evolving treatment is biological repairs, that is extracellular matrix graft jacket, relief pain but not improve the strength. Graft jacket is basically acellular human dermal matrix. Post-op rehabilitation is early passive range of motion for 4 weeks and then start active assisted range of motion for 4 weeks and then active range of motion. Differential diagnosis can be suprascapular nerve entrapment. Complication is infection caused by skin flora. Propionibacterium is common. Suprascapular nerve injury with aggressive mobilization of supraspinatus during repair or re-tear in up to 50% of the cases.